Hello everyone, and welcome to our second installment of the Preteen Vaccine Adolescent Immunization webinar series. Today's webinar is HPV Vaccine is Cancer Prevention, CDC's Clinician Engagement Initiative. All right, so for everyone on the line, thank you for joining us today. We want you to know that all of your lines are currently on mute, so you don't need to worry about muting your phone line or your computer. We are recording this webinar, and you will hear when the recording, that we were recording the webinar, and we'll know when the presentation slides become available online. We will send you an email through the same email address that you received the invitation for this webinar. There's going to be a question and answer session towards the end of the webinar. If you have a question, please type it into the questions section on your webinar panel at the bottom. We will be reading selected questions out loud for each of the presenters to answer. I am Jill Roark, and I am the team lead for the Adolescent Immunization Communications team here at CDC, where we are focusing a lot on HPV vaccination, which is going to be the focus of this webinar today. And thank you all for joining us. I know that some of you have been in our presentations before, and I'm going to just talk about a couple of things we've talked about in the past and then cover a few new things as well. So as many of you have seen this slide that's currently up, this is from the President's Cancer Panel report on accelerating HPV vaccine uptake. And in terms of how we as a nation will be accelerating HPV vaccine uptake, we can look at three main areas. So in terms of what our providers can do, they can provide a strong recommendation for HPV vaccination to adolescents and their parents, and then also use electronic office systems to support HPV vaccination in their practices or clinic. And then also, CDC especially is working with both providers and parents with communication strategies to help increase knowledge regarding cancer prevention benefits, efficacy, and safety of the HPV vaccines. So this is our main strategy going forward. So in terms of communications, we look very specifically how we can impact the HPV vaccine decision process, and that's why we're all here today, is to talk a little bit about how it is that we're communicating about HPV vaccine. And so there's three leverage points essentially. We can change the way that doctors think about HPV vaccine and the way that they recommend it. We can have parents ready to accept an HPV vaccine recommendation when they hear it from the clinician. And then during that clinician encounter, when the preteen and their parent is there with the clinician, we can help facilitate a better conversation. So we have some behavioral objectives and desired outcomes for each one of those three leverage points or three audiences. The first, with parent of a preteen, we want parents, as I said before, of preteens to accept that recommendation to start the HPV vaccine series, and we want them to do that so their preteen is able to finish the series before they turn 13 years old. And so through the work that we're doing, what we're hoping to see is by 2020, which is related to the Healthy People 2020 goal, the preteens will have started the HPV vaccine series and completed it by age 13. So during the visit, we want to improve that conversation that's occurring about all of adolescent immunization, including HPV vaccination, and really normalizing HPV vaccine. And so the outcome of that will be that every 11 and 12-year-old is initiating the HPV vaccine series on that same day that they receive their Tdap and meningococcal vaccines. So we mentioned before that we would be talking a little bit about the three pillars of cancer prevention through HPV vaccination, and essentially what we're trying to do is help clinicians become HPV vaccine champions, and it doesn't have to necessarily be the clinician that's putting the shot in the arm. There is a place for everyone here. So we're asking folks to commit to the cause by making HPV vaccination a priority in their practice, know the facts, so learn more about HPV vaccine as the primary prevention tool for many cancers, and also lead the conversation about the importance of HPV vaccination with your patients, your staff, your colleagues, particularly those colleague peers who are in pediatrics or family practitioners that are serving adolescents. Okay, so now I am going to introduce our conversation leaders, so those folks that will be leading the conversation with you today. First is Dr. Bernard Dreyer, who we are very grateful to have with us to lend his support and encouragement to our initiative. Dr. Dreyer is the president of the American Academy of Pediatrics. He'll begin his one-year term as AAP president on January 1st, 2016. Dr. Dreyer is a general and development behavioral pediatrician who spent his professional lifetime serving poor children and families. He's been a professor of pediatrics at NYU, where he leads the Division of Developmental Behavioral Pediatrics, and is the director of pediatrics at Bellevue Hospital, where he also works as a hospitalist. Next, we'll have Dr. Rebecca Perkins speaking about HPV vaccine from the gynecological perspective. Dr. Perkins attended Stanford University, Harvard Medical School, and completed her obstetrics and gynecology residency at Brigham and Women's and Massachusetts General Hospitals. Since 2005, Dr. Perkins has been on faculty at Boston University School of Medicine. Dr. Perkins' goal as a practicing gynecologist and physician scientist is to decrease overall rates of cervical cancer and also to reduce race and income disparities in the disease. Dr. Perkins became involved in cervical cancer prevention after seeing firsthand the devastating consequences of cervical cancer as a medical volunteer in Honduras in 2003 and has been very active in cervical cancer prevention since then. Dr. Perkins' current research focuses on improving utilization of HPV vaccination, and she's working on several projects with the American Cancer Society, the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, as well as CDC to improve HPV vaccination rates nationwide. And third, we'll have Dr. Sharon Humiston, who is going to summarize tips for success on focusing on how pediatricians and pediatric clinicians, as well as family practitioners, can increase acceptance and uptake of HPV vaccine. Dr. Humiston is a professor of pediatrics for Children's Mercy Hospital. She earned her medical degree from Medical College of Ohio in Toledo and is a Master of Public Health from the University of Rochester School of Medicine and Dentistry. Dr. Humiston completed a pediatric internship and residency at the University of Iowa Carver College of Medicine in Iowa City, as well as a fellowship at the University of Rochester School of Medicine and Dentistry. Dr. Humiston's area of interest is immunization-related health services research. Dr. Humiston has worked in the CDC's National Immunization Program as an educator for healthcare providers and is a member of the National Vaccine Advisory Committee. Dr. Humiston presents lectures on the state and national level on various immunization-related topics, including individual, routinely recommended vaccines, vaccine uptakes, communication, meningococcal disease, pertussis, and influenza. Now I will take this opportunity to turn the webinar over to our first conversation leader, Dr. Dreyer.
Thank you, and thank you all for joining us today and for your dedication to improving HPV vaccination rates. The American Academy of Pediatrics recommends giving the HPV vaccine at 11 to 12 years of age, but we hear from our members who are leaders in vaccination that they are struggling with parental hesitation and requests to delay. While some parents will ultimately refuse the vaccine, most trust the recommendations of their pediatrician, family practitioner, or nurse practitioner. Our recommendations matter, and how we say it matters more. Today's presenters have proven strategies to improve HPV vaccination rates at the 11 or 12-year-old visit. One simple strategy is to lead the conversation, the vaccine conversation, with parents and children by saying, today your child is due for 3 vaccines, HPV, DTaP, and meningococcal. With a little modification of our approach, we can address the concerns of parents and protect more children against HPV. And as we get additional data, we will be able to further refine the most effective messages that clinicians should be giving to parents and children. The AAP stands ready to support its members and the CDC in doing better. We have all the tools needed to make a change in the office. We need to keep the end goal in sight. We can prevent HPV-related cancers, and now is the time to protect our patients.
Good morning, everyone. My name is Rebecca Perkins, and I'm an obstetrician gynecologist at the Boston University School of Medicine and Boston Medical Center. As Jill Roark mentioned in my bio, I'm extremely happy this year to be following my passion by working with not only the CDC, but also the American Academy of Pediatrics, American Cancer Society, and American College of Obstetricians and Gynecologists on this topic. The slides that I'm going to present today were developed in conjunction with the American Academy of Pediatrics and the wonderful Dr. Humiston, and they will be coming soon to a website near you. The website will appear multiple times at the bottom. It's www.aap.org/HPV Toolkit, which is going to be a website having all the information you could ever want about how to improve HPV vaccination rates in your practice. I have no financial relationships to disclose. So in the next 20 minutes, I want to convince you that HPV vaccination is worth your passionate advocacy. HPV vaccine is worth giving long before infection, and your recommendation can make all the difference to a family's acceptance. So I'm going to start with HPV 101. What is this virus? So HPV is a virus that infects human skin and mucosal surfaces, and it is incredibly easy to transmit HPV. It is a skin virus, and it transmits about 1,000 times more readily than herpes. Because of this, at least 80% of people are exposed during their lifetime. And HPV has been shown to be a causal agent in 6 different types of human cancers and is classified as a human carcinogen. So how much disease does HPV really cause? Most people are not aware of the disease burden of HPV because we are learning more about this virus every week. We know that about 3 million Americans seek medical care related to a disease caused by HPV every year. 27,000 of these visits are related to an HPV-related cancer. About 8,000 Americans die every year from an HPV-related cancer, and this is as many deaths every year as measles caused in the pre-vaccine era. So we are vaccinating to prevent HPV-associated cancer. And in the remainder of the talk, I'll show you why current screening is not enough. We do have tools to screen for cervical cancer, but that's the only one. Cervical cancer is the most common HPV-related cancer in women, and we see about 10 to 12,000 cases of cervical cancer every year. But oropharyngeal cancers, specifically cancers of the base of tongue and tonsils, are giving cervical cancer a run for its money. Oropharyngeal cancers are more common in men, though women get them as well. And the other cancers caused by HPV are anal cancers, which are twice as common in women as men, again speaking to the ease with which this disease is transmitted. It's most likely autoinoculation while bathing that gives women anal HPV, and vaginal, vulvar, and penile cancers. There are great disparities in rates of cervical cancer based on a woman's access to screening and treatment. And despite our best efforts, we still have 4,000 deaths caused by cervical cancer in the United States every year. But most HPV-related morbidity is not from cancer. It's from the treatment in women of precancerous lesions. So I'm a gynecologist. I practice in the community, and in a clinic day I'll see about 25 patients, and a good 20% of them will be coming to me for a problem related to HPV. This can be genital warts, it can be an abnormal pap test, or it can be cervical dysplasia or precancer, which requires a treatment. And these treatments are called LEAP or cone procedures. And they are a wonderful improvement because before we had those, every woman had to undergo a hysterectomy in order to prevent cancer. And these are great because we can just remove the disease part of the cervix and preserve fertility. So what we do is we take a cone-shaped biopsy, which removes about 1 to 1.5 centimeters of the 5-centimeter cervix, and we have 330,000 women undergoing these procedures every year. Unfortunately, it's not a free ride. Multiple studies have shown that either the LEAP procedure or possibly the presence of dysplasia or HPV infection itself has been associated with obstetric morbidity, including about double the risk of preterm delivery, preterm rupture of membranes, and low birth weight. And as everyone on this call knows, when infants are born prematurely, they can have long-term developmental consequences as well as very high neonatal intensive care costs. So my feeling as a gynecologist is, why do I need to remove part of the cervix when my patient could have gotten a shot in the arm instead? But what about boys? The story about HPV-related cancers in boys is much less well known. Most people, especially most physicians, are well aware that HPV causes cervical cancer. But the oropharyngeal cancer story is one that is becoming more common and needs to be told, especially because there's no screening test for oropharyngeal cancers. Now, if you're really paying attention and you've been to the dentist recently and your dentist has been following guidelines, you may have noticed that your dentist pulled out your tongue with a cotton swab and had you move your tongue all around and look down your throat and felt the glands in your neck. They were looking for oropharyngeal cancers, 75% of which are caused by HPV. However, that would not prevent the cancer. It would simply allow you to get treatment earlier. The number of HPV-related tongue and tonsil cancers have more than doubled in the past 20 years. We see about 11,000 cases annually. 7,000 of these are in men. And it's estimated that oropharyngeal cancers caused by HPV will be more common than cervical cancers within the next 5 years. And some head and neck cancer surgeons believe that they're already more common. The typical patient presenting with oropharyngeal cancer is a college-educated white male in his 40s. Why is this? Why does HPV cause so much disease? Well, because it's so easily transmitted that almost everyone, over 80% of people, will be exposed. And while we used to think HPV was the common cold of sexually transmitted infections and would go away, we're now learning that infections may in fact be lifelong. The most common route of acquiring HPV is sexual intercourse, by which I mean penetrative vaginal, penile, or vaginal anal intercourse. However, because HPV is a skin virus, it can be transmitted by genital touching that does not involve penetration, anal genital, oral genital, and manual genital contact. And studies indicate that at least half of high school students have already engaged in vaginal penile intercourse. This is about 1/3 of 9th graders and 2/3 of 12th graders. So it's the unusual high school senior who makes it all the way through prom without having their first sexual experience. And nearly 1/4 of high school seniors have had multiple partners. But again, you don't actually have to have sex to get HPV. This very interesting study looked at the frequency with which HPV could be detected shedding in the vagina prior to the first vaginal penile intercourse. And they found that nearly half of women had vaginally detectable HPV prior to their first vaginal sex. And most of these women reported non-coital behaviors such as experimentation, oral genital contact, and other forms of touching that could explain genital transmission. And these are two of my favorite studies paired together in a single slide. These are studies of very, very special college students. The green line is college women and the yellow line is college men. And I say that these are very special students because these are among the 1/3 of high school seniors who had never had sex before they got to college. And then they're in, I don't know what percentile of responsibleness, but they actually went to university health services to obtain information about contraception and safe sex before their first sexual experience. And then they were willing to sign up for a study where their genitalia were swabbed every 4 months for 2 to 4 years to look for the detection of HPV. So these are incredibly rule-following, responsible college students. And look how fast they were infected with HPV. Within the first year, 30% of college men and women had acquired HPV, and by the second year, over 60% of the men had acquired HPV, and by the end of college, about half of the women had acquired it. And we used to think, based on studies that looked for the presence of vaginally shedding HPV in young women that HPV infections would go away. Because in fact, most women will stop shedding HPV within a couple of years after the infection is first detected. However, new data indicate that the infection may not actually go away, but in fact remain dormant for decades and then reactivate later in life as the immune system declines. And this data makes a lot of sense to me in my practice because I have many women with newly positive HPV tests who are in their 40s or 50s, have been married for decades, and my record of the length of abstinence prior to a newly detected HPV infection in one patient who had not had sex in 26 years. So this data comes from over 700 women aged 35 to 60, and they found that only 13% of newly detectable HPV infections could be attributed to a new partner, while 85% of these infections occurred during periods of abstinence or monogamy. But early vaccination can prevent these initial infections. There's been concern raised in the media about vaccine safety, but in fact, HPV vaccine safety is well proven. The HPV vaccine is a little bit different than some other vaccines because it doesn't actually contain any virus. It's simply the viral envelope, so there's absolutely no risk of it causing the cancers or diseases it is intended to prevent. Unlike other vaccines, it also causes a much more robust and effective immune response than wild-type infection. HPV vaccination is recommended for all boys and girls ages 11 to 12, and then catch up for older young men and women who have not been previously vaccinated. In terms of HPV vaccine safety, we've now given over 170 million doses worldwide, and the most common adverse events are mild. For any serious adverse events that were reported, there was no unusual pattern or clustering that indicated they might be due to the vaccine itself. And our findings are similar to the safety reviews of other adolescent and childhood vaccines. Specifically, studies have looked at large groups, at this point over 4 million girls who have girls and young women who have either received or not received HPV vaccination, and they found no increase in any category of illness, including emergency room visits, hospitalizations, autoimmune disease, thromboembolic disease, neurologic disease, and of course death. So the vaccine is safe. HPV disease is terrible, but does the vaccine work to prevent HPV disease? And the answer is yes. In the United States, we're having this webinar because our rates are not where we would like them to be. Only 33% of our girls are fully vaccinated, and we would like that number to be 80% by the year 2020. Yet, despite this, in our 14 to 19-year-olds, after vaccination was introduced, we saw a 56% decline in vaccine-type HPV. But what we really want to look like in the United States is Australia. They had an incredibly successful introduction of HPV vaccination into their population in 2007 and have already started to see dramatic benefits in terms of disease reduction in their young men and women. Between 2007, when the vaccine was introduced, and 2011, Australia has noted a 93% reduction in genital warts in girls younger than age 21, and an 82% reduction in boys, even though the boys were not receiving the vaccine. So strong evidence of herd immunity. And warts are terrible, and I've had people cry over warts and their relationships end because of warts. However, we're really vaccinating to prevent cancer. And the Australian data is very encouraging about the ability of the HPV vaccine to prevent cancer in the real world. And it also speaks to the vast importance of vaccinating early. When you vaccinate at the ages of 11 and 12, you have essentially no exposure to HPV, and you get much higher antibody responses compared to vaccinating older. And what that translates into in the Australian data is that girls who received all 3 doses of HPV vaccine by the age of 14 had a 75% reduction in high-grade cervical precancer, those precancers that require LEEP or cone procedures to treat, within 5 years of being vaccinated. when they had reached the age of 15, 16, or 17 by the time they got their vaccines, that effectiveness dropped to 35%. So half of what it was when they received their vaccines by the age of 14. And that's why it's so important to vaccinate early. This pyramid describes the current burden of genital HPV disease in the United States. So we see about 1.4 million new cases of low-grade abnormal pap smears, about 350,000 new cases of genital warts, about 330,000 new cases of that high-grade cervical dysplasia, or CIN2-3, requiring leprechaun procedures to treat, and 10 to 12,000 new cases of cervical cancer with about 4,000 deaths every year. Now, if we reached 80% vaccination rates, if we reached those Healthy People 2020 goals and looked like Australia, we could shrink our pyramid to this: a 35% reduction in CIN1, a 92% reduction in genital warts, a 46% reduction in our high-grade dysplasias requiring LEEP and cone procedures, which would be a 75% reduction if we get everybody vaccinated when they're supposed to be, with corresponding reductions in cervical and other HPV-related cancers. Now, I mentioned that we have no screening test to prevent oropharyngeal cancers, and that makes it impossible to do a clinical trial where you look for the endpoint of oral cancer precursors to look for the vaccine effect. So what they had to do instead was look for decreases in rates of oral HPV infection. And in fact, in the clinical trials, they found an estimated vaccine efficacy of 93% for oral infection with HPV 16 and 18. And that's really important because 95% of oropharyngeal cancers are HPV 16. So in summary, HPV exposure is ubiquitous. HPV causes many cancers. HPV vaccine is safe. HPV vaccine is effective. So why isn't everyone vaccinated yet? And I will now turn it over to Dr. Humiston to answer that question.
Thank you, Rebecca.
You're welcome.
Is my audio, can everyone hear me? Okay. So I'll be talking about making a strong recommendation about HPV vaccine to parents in primary care. I want to say that my comments are largely based on slides created by Jill Roark for the CDC, the HPV Speakers Bureau, as well as research that was presented as recently as this past week at the April 2015 Academic Pediatric Association meeting in San Diego. So you are hearing it right off of the presses. I'm going to be making just 3 points. Number one, you need to recruit your whole office team to take a role in HPV vaccination communication. I'm not sure who's on the phone today, and I don't know how many of the office nurses and MAs that we have, but we need them as well as the advanced practice nurses and primary care doctors to hear this message, because the whole team has to do this as a concerted effort. The second thing I'll talk about is recommending HPV vaccine the same way and the same day as other routine adolescent immunizations. My third point will be, and I'll go into quite a lot of detail, using a practical communication strategy when a parent does have a question. Not every parent's going to have a question, but when they do, how do you address it? So point number one, recruit your whole office team to take a role in HPV vaccination communication. I say this partly based on the new research that Mandy Dempsey talked about last week at the APA meeting, but also on the basis of old research that I did. We were looking at childhood vaccines at that time, and what we found was that parents talked about instances where the front office people scared them away from a vaccine. For example, the registration people said, oh, you're due for the MMR vaccine. I would never get my child that vaccine. And that, even though the registration person had no background in medical information, the parent took it as part of the team saying, don't get the vaccine. and they took that person's recommendation. So your whole office team needs to hear Rebecca's talk about how important this vaccine is. One of our problems, I think, is that parents don't know about the consequences of HPV. I mean, a lot of scientists are just learning about this. So having the parents understand it and having the whole office be in on letting them know this. Okay. So be sure that everyone who has patient contact gets educated on HPV. You didn't know you were at a Train the Trainer session, but that's exactly what you're at right now. The point of today is not only to talk to the hundreds of people that are on the phone, but to have you become the trainer and turn around, take these slides as well as Rebecca said, the AAP slides that will be in the toolkit, and CDC slides, which are already on their website. So all of us taking this information and going forth with it, and I will also say, in addition to talking to your office staff, talking to your legislature about it. All right. The second point is everyone in the office needs to know their role in immunization communication. So, for example, the registration people hand out the vaccine information statement. You know what I mean, those CDC one-pagers that are required by law to go out before vaccination. Well, the registration people need to know that HPV is one of the routinely recommended vaccines that will be given at that visit, so that she's giving that out as part of the package. Then, for example, say the nursing staff brings the patient back to the room. As they're talking about what to expect during the visit, they include in that bundle the normal process, which includes HPV vaccination. And they know not to put it and then there's this optional additional vaccine. And then, let's say, the nurse has handled the routine questions about, well, will it hurt? How can I deal with the pain? Then the primary care provider only has to answer the last hard questions. So by having it so that everybody knows their role in the communication process, there's no repetition, and the whole job gets done efficiently. Key staff roles, we talked about the presumptive or normative plan so that everybody knows this is part of the routine, giving and explaining the vaccine information statements, obviously vaccinating, and arranging for the next dose. I forgot to talk about that part. After this dose is in, the parent needs to understand that this is a series, not just a one-time vaccine, and that series, we want to get it in pretty efficiently. Okay, my second point, recommend HPV vaccine the same way and the same day as the other routine adolescent immunizations. By same way, what I'm talking about is grouping all the adolescent vaccines and recommending them all in the same way. Again, HPV is not some additional add-on. And I think that got started because the Tdap is required for school. In some places, meningococcal vaccine is required for college entry. In New York State, it's at least a conversation about meningococcal vaccine is even required to go to camp. So those sort of stuck in people's minds as, quote, the required ones, and HPV got this bad reputation as an add-on, but it's not. It's just as routinely recommended as the others. So when you're recommending it as part of the package of protection. And then same day, what I mean by that is recommending HPV vaccine today, because if you let this young person out of your office, we know that adolescents don't come to the office every day. I mean, we try not to let babies and toddlers out of the office without all of their vaccines either. But at least with babies and toddlers, we have the expectation that they'll be coming back every couple of months. With adolescents, once you let them out of the office, you don't know when they're coming back. And so we want to give HPV vaccine the same day that you give the Tdap and the meningococcal vaccine. Now, some people say, well, they only have 2 arms, it's going to hurt. Which would I prefer, an owie or cancer? Making a presumptive statement like this, today, Michelle should have 3 shots that will protect her from the cancers caused by HPV and infections causing meningitis, whooping cough, tetanus, and diphtheria. In that one sentence, you have given them the reason for the vaccinations so you can bill, and you've taught them the purpose of the package of protection that you're offering. And I think it's also, one of the things about it is that it's a very positive statement. It's about, today we can protect her from. One of the things you'll notice about this is that it uses the presumptive, we will, you should, rather than the participatory style. Don't start with an invitation like, oh, now let's discuss how you feel about the vaccinations for adolescents. That's been shown to not be as effective, and it also makes it so you're opening a can of worms when you didn't need to, and so you're using up your time that you could use to describe the importance of doses 2 and 3. Okay, my third point. You've gotten the routine recommendation across. Now, once in a while, you're going to have a parent who has a question. One of the things, I love being a pediatrician because I think that we are not a group that likes to argue. We're a warm and fuzzy group of people. But one of the problems with that is that when a parent even has a question, we interpret it as resistance and controversy, and we don't want to go there. So one of the things I'm going to say is, when a parent has a question, don't panic. Interpret it as a question, the question as a request for reassurance from you, the clinician they trust with their child's health. It's not opposition. It's a request for reassurance. And then go from there to clarify and restate their concerns to make sure that you understand, because nothing wastes time like answering a question that the person didn't have in the first place. So say something like, it sounds like you're concerned that the HPV vaccine isn't necessary because Emily's a virgin. Am I understanding the question? One of the other things Mandy Dempsey from Colorado talked about last week was that using that motivational interviewing style where you bring the conversation back to yes is an important way to get the conversation back on track. So by saying, I think I'm hearing you, am I understanding the question? Well, if the answer is yes, then the conversation flows forward in a different way. And then address the parent's specific concerns. And this can be done, CDC has this wonderful sheet. All you have to do is Google tips and time savers, and this will come up. I love this sheet because it has this is designed for providers, not for providers and the whole office staff. This is not to give out to parents. This gives you scripts on how to say things in a quick way so that you get across the accurate information without spending a lot of time on it. We're not going to go into all of the answers, and Rebecca has already given you the medical information that supports these answers. So I just want to say that after today, when you're giving your talk, handing out these tips and time savers, I think is a great way to have everybody prepared for answering the parent's questions. What if you do get to the point where a parent actually declines vaccination? One of the things that I think is important, just like we were talking about interpreting a question as wanting reassurance, when a parent declines, interpreting it as delaying, not shutting the door for all time. I think that's really important because you will have more opportunities. Because delaying is the risky choice, consider asking parents to sign a declination form. And AAP has their declination form online, and you see the website there. My point in this is that I think that by having the parents sign a declination, what you're saying is you're choosing the risky thing. And so I want to make sure that you understand that you're taking the risk burden upon yourself. I mean, who knows, heaven forbid that, 10 years from now, 15 years from now, this kid ends up having cancer. You also want to document that you did the standard of care thing, which was to give a strong recommendation. That is the standard of care in the United States. So you want to document it, but I believe that even more important, you want to get across the point to the parent that you see the vaccination as the less risky thing. Now I want to show you some videos that I love. This is from Just Another Shot, Reframing the HPV Vaccine. Again, if you want to find it without memorizing this website that you see across the bottom, you can just go onto YouTube and Google Minnesota Department of Health HPV, and you'll see this. Basically what's happening is the doctor's saying, well, your baby looks great. I want to give today the Tdap and IPV and HPV vaccine, and oh, by the way, there's this other vaccine. It's called pneumococcal vaccine.
Kayla looks fantastic. Before you go, there are a few vaccines we give at the 2-month visit. Rotavirus, Hib, polio, the second dose of hepatitis B, and the DTaP vaccine against diphtheria, tetanus, and pertussis. Also, there is one other vaccine you could consider.
What's that?
The pneumococcal vaccine. If you're interested, we could add it to the list, but it's up to you.
And you saw the mother's sour look like, well, why would we give an extra vaccine? Would we ever present a routinely recommended vaccine as a, and oh, by the way, do you want this extra vaccine? Of course not. That was just for emphasis. How we recommend childhood vaccines is as a package of protection, and that's what I'm asking you to do with the adolescent vaccines as well. And when we recommend childhood vaccines, we do so with a full understanding of and a conviction in each vaccine's importance. That's one of the reasons why I think that Rebecca's talk is so incredibly important, is because I, as a pediatrician, don't see cervical cancer or oropharyngeal cancer. As Rebecca said, oropharyngeal cancer is going to be in middle-age men. So I'm not seeing it, but I need to educate myself in my office about it so that I'm saying these things with the same level of understanding and conviction that I do about Hib disease and pneumococcal, which unfortunately I am all too familiar with.
I told you, this hockey is just not a good idea. Well.
Oh, so that's going to be sore for a few days, but it should get better by the end of the week. Let us know if it doesn't, okay? All right. Now, I see that you turned 12, so since you're here, this would be a great time for those vaccines which are recommended at this age, which are HPV, Tdap, meningococcal. Are there any questions about that?
Yeah, the HPV, that seems like something that could wait until she's a little older, don't you think?
I think I get your drift, and I know it seems kind of soon, but the thing is, the vaccine are recommended at the youngest age, for which they've been proven safe and effective. No matter what the disease, you want to make sure that immunity is in place before the exposure happens. A bonus is that at Isabella's age, kids respond much more vigorously to the vaccine than older kids and adults, and that might make even better protection. It's also convenient because, well, there are 2 other vaccines due at the same age, and Well, those two and the first dose of HPV can all be given at the same appointment.
Okay, but I just wonder what we might be opening the door to.
Okay. Some people have had that worry. And there's research been done that has studied that question, and they found no more sexual activity among girls that have had that vaccine compared to those that hadn't. So that may have eased some minds, especially considering what you get in exchange. I think it's pretty amazing that there's a safe and effective way of preventing cancer. I'd feel a lot better if we got her protected today.
Okay.
He does a great job. First of all, he seizes the moment. He's dealing with her sprained ankle, but he looks at her immunization record because he knows the likelihood that this healthy young athlete may not be in his office again anytime soon. Secondly, he doesn't profile, meaning he recommends the vaccine even though this girl doesn't look like she's interested in having sex anytime soon. Number three, he bundles the recommendation. He offers all the vaccines all at once. He asks for the mom's questions. He answered mom's question accurately and calmly, not as if he's going into an argument. His answer was a bit long-winded, but got to the point and wrapped it up in just a couple of sentences. When mom asked her second question about I'm worried about what this will open up. The innuendo was that what it opens up, the can of worms that it opens up is sexuality. And he says, some people ask me about this. So it validates the mother's concern, and makes it normative, but he doesn't stop there. He stays positive and answers. He says, and finally, he ends up with, I'd feel better if. And I love that because I think it comes across in a way that's so genuinely caring. So, I mean, obviously you're not going to say those exact words, but staying in the mode of not, I'm doing this because I'm, doing a quality improvement project and we're trying to increase our immunization rates, but because I care about this kid who's in front of me. That's the end of my comments. Thank you so much for listening.
All right, well, I want to thank all three of our presenters for doing a great job, and I believe that we've had some questions coming in, and our moderator, if you'd like to go ahead and start with first question, that'd be great.
Okay, we have a question from a Ms. Torres. If a teen received the previous HPV number 1 and number 2, and the number 3 vaccine will be the new HPV vaccine, do they have to start over with the new vaccine, or are they okay?
At this time, can you hear me?
Yes.
Okay. At this time, CDC has not given detailed recommendations about the series, other than to say that just the substitution of HPV-9 for the other formulations is acceptable. So if you've already had, for example, 2 doses of HPV-4, the quadrivalent, you can switch over to the 9. In June of this year, ACIP will reconsider, a more complex catch-up schedule, but at this time it's simply a substitution for, for whatever dose needs done.
This is Dr. Dreyer. Just to add to that, but clearly, that's the recommendation, and clearly you won't be protecting adequately for the additional types that are in the new vaccine, but will be adequately protecting for the previous types. So that's what substitution means. You're basically giving the equivalent of with one dose, you're perhaps having some protection, but not completely adequate.
We have a question from Chris Loophole. Has vaccination been proven to decrease mortality from cervical cancer compared to routine cervical cancer screening?
This is Rebecca Perkins. I can answer that one. So because usually the lag time between infection and cancer and death from cancer is more than a decade and often more than 2 decades, the vaccine has not been around long enough to decrease mortality from cervical cancer. What we expect to see more quickly than decreases in mortality from cervical cancer are decreases in the number of women who have to undergo invasive LEEP and cone procedures to prevent cervical cancer, and we have seen decreases in these cervical precancers.
I want to emphasize that, you know, we talk a lot about the cancer, and Rebecca did a lovely job of reminding us about the precancerous lesions and the importance that has in a woman's life. Parents sometimes ask about the problem, you know, like that they're afraid that HPV vaccine is going to harm their child's fertility in some way. And what we actually know is that having a LEEP procedure can lead to obstetric problems over the long run. So it's to avoid the vaccine for fear of fertility problems is exactly opposite of what you should do.
We have a question from Sandra Talley. How long does immunity last?
We know that it's at least 10 years. Again, the vaccine manufacturer and CDC are working together to monitor the duration of immunity. And one of the things about HPV is it's especially important to get people vaccinated young because of the changes in the cervical environment. You know, the cervix of an adolescent is different than the cervix of an older person, and you want to protect people early because of those differences.
Okay. We have another question from Beth Bellin. We have parents who turn to their preteen or teen and ask them if they want the vaccine. How would you handle this?
I personally worry about that a lot, just as much as you would. You wouldn't turn to your 2-year-old and say, "So how do you feel about hepatitis A today?" I think that I would address the dyad and say, I want to make sure that you understand that the risk that you're assuming by waiting, and talk about the very reason, you know, that Rebecca again went over why we vaccinate at a younger age. And so, and emphasizing that avoiding an owie today in trade for protection from cancer is not a great trade-off.
And people have also described success when addressing the children, talking about a lot of kids that experience with plantar warts or warts on their hands and feet, and saying, you know, this vaccine prevents against, you know, you had that wart on your hand that took 6 months to go away. This vaccine is going to prevent against a wart on your penis or your vagina, and they look horrified and tend to accept the vaccine.
Yeah, and this is Dr. Dreyer. I agree with that last statement as well. I've used that information to be helpful with the adolescent. And also, what I find is if I include the adolescent in the initial discussion, when I talk to them, then the parent is less likely to turn to them after the fact. If you just talk to the parent, then sort of appropriately the parent is involving the adolescent after the fact. So just remember, I think, to involve both of them together and have some eye contact with the adolescent about it as well as the parent in your initial discussion.
It's analogous to getting kids not to smoke by telling them that they will look worse if they smoke.
Right.
Okay, we've actually received a few questions asking whether or not the slides and webinar will be available online. Jill, do you want to answer that question?
Sorry, I was on mute. Yes, we will have the slides available. What we're going to be doing is actually posting the recordings of these presentations. And so to be compliant with the federal government and disability standards, it takes us a little while to make those captioned and get them online. They get posted on the CDC Streaming Health YouTube page with a link to our website. So once we have those up, we'll start sending out announcements. In the meantime, we will go ahead and send out the slides to everyone so that you do have the slides.
And I know it's a little bit after 12 now, so Jill, if you're okay with this, we were going to move into the polling questions.
Yeah, let's do the polling questions real quick and then we'll tie this up.
We are asking a couple of questions just to get your feedback of today's webinar, and we'll launch it, and you should see the questions on your screen. Okay, we're going to close this one. And then we will launch the second question. Okay, we're going to close it.
All right. Well, thank you everyone for joining us today on the webinar. And again, we will be sending out information on how to get to the recordings, and then also we'll send out the slides. Thank you very much. If you have any questions ever, please send us an email to Preteen Vaccines, that's plural, @cdc.gov. Thanks and have a great day.